happy to have Dr. Doug Devries here. He is the co-founder of Eye Care Associates in Nevada, and we're going to be talking about point of care testing today. Thank you, Dr. Devries, for being here.
You're certainly welcome, Jackie. It's great to be with you. And yeah, point of care testing, it actually dovetails really nicely into my practice and how I became involved in dry eye, because 30 years ago, I started a medical surgical co-management group, and I had a partner, a very aggressive ophthalmologist, and his goal when he came out of residency, which I joined him just right after that, his goal was to do enough surgeries to fill up Dodger Stadium, since he was from Santa Monica. And by the way, we now have passed Dodger Stadium, and we're on our way to the LA Coliseum and filling that, which was, over 100,000 people. So very, very busy surgeon. And as we know now that we didn't know then, he came to me at one point and said, we got to figure out this whole dry eye thing. Because we're hearing more, and there was a lot, within ophthalmology, optometry about dry eye and how it could possibly affect outcomes. So he said, we need to figure it out. And by we, I mean you, because obviously if he was going to fill Dodger Stadium, he couldn't spend time, being involved in ocular surface conditions. And what we've really found out is that within a surgical practice is that those numbers are so much higher than what you typically find in the national averages, say 18% of your patients. I mean, it's closer if you take a look at some of the studies that have been done. 80% of those people have some type of level 2, level 3, or level 4 dry eye. William Trattler did that several years ago, where we saw just what that percentage was. So really became important in our practice because it was such a high percentage. And that's how I became so involved in looking at that, and why it dovetails so nicely into point of care testing when that became available.
That's a good point. I mean, for a surgical practice, I mean, it's something that you really can't ignore. Otherwise, your outcomes are going to suffer, and you may not be upset directly, but indirectly, your surgeon will be upset with you that is probably happening. So this is great. Let's talk a little bit about point of care testing, and how did you come to learn about InflammaDry? This is the only point of care testing for detecting the presence or absence of the MMP9 biomarker for ocular surface inflammation.
Well, it's interesting, Jackie, because we've known about MMP9s and being a non-specific inflammatory response in the eye, whether it's allergies, whether it's infiltrates, whether it's dry eye, whether it's EBMD. I mean, the epithelium releases this proteolytic enzyme called matrix metalloproteinases. And so we've known about that. So when this test was developed, it was developed by Dr. Rob Sambursky from RPS. And I had known Rob through the adenovirus test. And so I was very, very excited when there was this test with this sensitivity and specificity that was being released. And so I jumped on it right away to say, I want to know which of my patients have a high MMP9 for a variety of reasons. I mean, you have to differentiate it then. Is it dry eye? Is it allergy? Is it infiltrates that the patient has? Or is it something like epithelial basement membrane dystrophy? So I thought it did a good job of, just like we would order a SED-rate and a C-reactive protein for a patient that possibly could have temporal neuritis. We need to note, is this inflammation present? Because it really helps differentiate some of the diagnosis as well.
And then how does this biomarker, how is that important to the wellness of the ocular surface?
Well, with a high MMP9, regardless of what the cause, we can start to see epithelial breakdown. And what I liked is, number one, it was something that a lab test that could be done right away, that I could relate that to the patient and say, based on this test, you have this inflammatory response. And what I'm finding, and then, as we do other point of care testing, it just helps narrow it down. But it really is something that you give the patient something to grab a hold of, that you're not just winging it, you're actually finding a lab test, which then also, when we take a look at what is that treatment doing, then the patient can get involved, the patient can, and I mean, I learned, years ago, what's the first thing a glaucoma patient asks you when you pull the tonometer away? What's my pressure? Right? They like
Absolutely.
numbers. They want to know that. And
Yes.
so if there's a point of care testing, that's the first thing. They'll say, doctor, how's my inflammation doing? And how is the treatment coming along? And it'll be interesting if it's coming along nice. We've also learned about flares and what can happen
Mhm.
if it's coming along nice, and then all of a sudden it's allergy season. We may see it rise again, and then you start talking to the patient in terms of a little different direction and helping differentiate treatment as well.
And then what patients are you performing this on?
That's an easy one because we do a speed questionnaire, and anybody with 6 or above
Mm,
automatically gets the point of care testing unless their insurance precludes it. And then we'll approach them with an ABN to have it. And it's amazing. A lot of these patients that are used to doing, if they switch insurance, they're willing to go ahead and pay for that information once they understand it. So it isn't necessarily just if it's covered by insurance, but we let the patient know up front if their insurance has decided that that was information that they shouldn't know.
got it. And then how does the results of this assist your treatment? So if the test is positive, what approach do you take to educate the patient that like some clinical event is occurring? And then same thing with when it's negative. How does this change which path you're going down?
Well, when the patient is unhappy, it's negative, you got to keep on looking. And so you really have to then say, okay, what is causing this inflammation? Why are we positive on that? And that can often be something like look a little closer, look at that staining, look and see if it's epithelial basement membrane at a subclinical level, at a real low level where you're starting to see that. And then you can adjust that treatment according to that. If it happens to be negative completely, well, then you're going to head in a different direction. You can certainly do plugs a lot sooner. It really dictates what you're going to do along your treatment plan. The vast majority of people, though, they are positive, that are 6 and above. And then at that particular point, what you're doing, you're starting some type of anti-inflammatory therapy on that patient. So it not only helps guide the initial diagnosis and what you're going to do, I think it benefits 2 people in the room. It benefits the patient. It also benefits the doctor, that now you say, okay, well, I have inflammation and I'm not going to treat it. No, I
Right.
mean, you have inflammation, is telling you you have this lab test, and therefore it helps justify what you're going to do and what you're going to start that patient on prescription wise.
I think that you're right. That does really resonate with the patient. Everyone certainly understands what inflammation is. Like that, you don't need any sort of medical degree to understand. Like, oh, I have inflammation here or there, and you're right. It does probably feel very foreign for a patient to think, well, we're not treating inflammation. Like, what are we doing with that? So that's a good point.
Yeah, and be kind of like your doctor, your primary care doctor, saying, "Well, we got the results back from your lipid profile, and
Yeah.
you're at 275, but we're just going to see what it does over the next couple of years."
We'll watch that. We'll see
You're
how
going,
that
wait,
works out.
wait a second, what are you doing? So,
And that actually does kind of bring up a point. So, prior to you doing point of care testing, did you find patients were maybe more hesitant to start a treatment? And then once you sort of bring in point of care testing, there's this actual lab test that shows there's inflammation, which maybe might make a patient feel more motivated to start a treatment.
I don't think there's any question about that. I think when you are doing point of care testing and you're able to triangulate on, and I include mybography as part of the point of care testing as well, looking at osmolarity, but when you're able to triangulate that, they feel better about what you're telling them. And I think that they realize then that, yeah, something has to be done.
Yeah.
And so I think they are more accepting of that.
Well, I think patients are also more involved in their care. I certainly find that with my patient base, they want to know numbers. Am I what's our approach? What are my options? Like I do feel like patients are more involved, and so probably when you have actual data points to sort of point to, or mybography images to show that osmolarity, it becomes more of a collaborative effort, which is really great because that means the patient buy-in is there, and they're actually going to be doing these treatments that you're recommending.
And when you explain to them that you're going to be monitoring their progress and see what happens to that inflammation, they like that idea. It's
Yeah.
follow-up labs. It's following, what is your treatment really doing at that point? So, and if, I mean, we know patients will drop off treatment sometime and their inflammation goes back up. Well, we need to address that again.
Yeah. switching gears a little bit to talk about your surgical practice, how important is it to, buff the surface to optimize the ocular surface prior to a surgical procedure?
Well, we're realizing more and more how much outcomes can be out if you don't optimize the surface. I mean, the most important measurement that goes into biometry is the keratometry reading. And, the studies have shown that if that keratometry reading and how far it can be off with an inflamed eye, with a surface that is not optimized, and it can end up in the wrong IOL selection. And I think the key is prior to this, we used to justify this as like, oh, hey, this patient turned out to be a +1.25. How did that happen? Well, it's just got to be the vertex distance of the IOL in the capsular bag, and Prentice's rule shifted it. And then we're finding out, yeah, it was a bad surface and the case were bad. And so we know, and Alice Petropoulos has done a study just looking at surfaces with hyperosmolarity and how far off they can be, and it quite often can end up in the wrong IOL selection. So if you can titrate those and you can narrow that to get closer to your target, I think it's so important. And patients get that. Patients understand if you're trying to optimize their outcome, if you're trying to get the best possible results.
I mean, this is probably a difficult question to answer as every case is very different, but if you're finding these patients that, don't have great ocular surfaces and you really don't want to send them into a surgery, what do you find like your typical time frame is to wait until we get a better surface before we're more comfortable sending them into surgery?
That's not an unreasonable question. It's a great question, Jackie. And it depends on how fast the patient wants to get to surgery. If the patient wants this done, then I'm going to suggest, treatments where they're going to give them the fastest type of results to optimize their surface. So we might get into another area of thermal pulsation at that point, instead of just simply starting them on an anti-inflammatory and taking it real slow. So their motivation is my motivation. If they want to get it optimized and they want to get to surgery as soon as possible, then we'll look at different procedures that they can get to it a little sooner. And some of that can be as soon as 2 or 3 weeks.
Oh, okay. Yeah. So you're in this surgical referral center. Do you recommend to your colleagues and your peers that are referring patients in that they maybe include InflammaDry as part of their workup before they're referring a patient to your office?
I love to share the information with all the colleagues that refer, that Trattler data that showed that 80% of patients that are referred in have level 2, 3, or 4 dry eye, and really encourage them. And I think point of care testing is a huge part of that. Ask the questions, whether it's a questionnaire or whether it's just asking the questions in the case history, and then do the point of care testing when you see that. And I think that because it helps motivate treatment, there is not a referral center in this country that wouldn't love every patient pre-screened, have InflammaDry done, and initiate treatment prior to the referral. I mean, because a lot of times you then have to slow that patient down. And now they have this mental mindset: I'm going to go in, I'm going to get this cataract, I'm going to take care of this glare, I'm going to take care of this problem of decreased vision. And now all of a sudden you're slowing them down. So I don't think there's a center around that wouldn't love to see the point of care testing initiated, and where that patient has had that InflammaDry. Because then there's a tough decision, like we talked about a little bit earlier. I'm going to tell you have inflammation, but I'm not going to treat it. I mean, that's a tough decision. And so I think it just motivates everybody in the exam room to treat and to be treated. And so, yes, absolutely. I'd love to see our entire network doing that on patients and being able to capture that information ahead of time.
Well, I think it's also important for the referring doctor, because this patient that you refer to you're going to tell them they have this inflammation. And this patient might say, oh, well, why didn't my regular doctor also tell me that? So I think it's, it certainly gives the patient, even if that referring doctor is not going to be treating the dry eye for whatever reason, at least they're prepping the patient. So the patient's not like, ugh, like what, why can't I just have the surgery right away? It's more like everyone's on the same page and there's multiple people addressing this or discussing with the patient before they go.
That is absolutely a fantastic point. And that is just doing the InflammaDry and letting them know, okay, they may want to initiate some other treatments before you actually have surgery. And then it's like everybody's on the same page. We told you that was going to happen, because it's an awkward conversation then when you tell that patient, and you're right, they say, well, why didn't my other doctor tell me that? Yeah, why didn't my other doctor tell me that? And so, no, you're right. And I think if for no other reason you say, well, I really don't want to run a dry clinic, I really don't want to treat that, tell the patient. And that's a great way to do it, is actually get that inflammation, the MMP9s, and say that, they may want to do this before they actually get going on you.
So point of care testing, it certainly seems like an easy enough thing to incorporate into, workups, or even before you refer a patient for surgery, for example. But can you talk a little bit about the financials of this? Is this reimbursed? You said a little bit about insurance earlier. If is it covered by certain insurances? Can you talk a little bit about that?
Yeah, it is. It is covered by most insurances, and when something isn't, we offer the ABN form. And I will tell you that the point of care test itself, while it will create a positive cash flow, isn't where the revenue is in the practice. What it is in the subsequent visits and the treatment and the procedures that you're going to do on that patient, that's where the revenue lies. I mean, honestly, I would do the point of care tests like InflammaDry at a slight loss, just to get the information to get those patients into the stream of being treated, because then that's additional procedures. It's thermal pulsation, it's microblepharal exfoliation, it's IPL, there's just so many downstream procedures and visits, and each one of those is a level 3 or level 4 visit. And then you get into the revenue, it's positive on it. But the real revenue that comes for the practice is, setting yourself up to do additional procedures and visits on those patients.
I feel the same way about my biography, that I'm not necessarily charging patients for, but it's so valuable to have that piece of information. And the same for InflammaDry, that the value and the value that it brings to the patient, like we were talking about earlier, I think is, even if it's a break-even situation, you're still getting a lot more information, and it's what comes down the road that you see those financial sort of dividends from.
Oh, completely agree on how that works, and that's why it's and I've had doctors before say, I just don't know that you make a lot of money off of point of care testing. No, but you're not going to lose money.
Right.
And to tell you also, I had a situation where we closed down a clinic, so we let the CLIA waiver go away. Well, the person that let it go away when ours came up on our main clinic let that go away too. And so all of a sudden, I couldn't do what I normally do until we got it reinstated. And I felt like I was handcuffed in the exam room, that I really didn't have the information, my dialogue that I'd explained to patients. I'm saying, well, you have inflammation. They say, well, how do you know?
Yeah.
Because I know,
I'm Doug Devries.
Yeah,
I don't know if you know.
Come on. But it was just awkward. I felt like I just didn't have enough information, just on that basis of not where I had to go for a month or so and not be able to do it. And by the way, we took a look at what that did for revenue, and it did have an effect on the bottom line during that period of time when we weren't doing 2 eyes on each one of those visits. So it does have an impact.
Well, this has been great. Thank you so much, Dr. Devries. This has been a good conversation on the importance of MMP9 testing with InflammaDry in our ocular surface disease patients. Thank you so much for sharing your expertise with us.
Oh, you're certainly welcome. And I think the beauty of this is it doesn't have much of a footprint, and all you need to have is the CLIA waiver. And it's basically buy a test, use a test, bill a test. It's that easy. So I think that there really is some attributes to the InflammaDry, and being able to integrate that into practices.
Yeah, great. Thank you so much.
Thank you, Jackie.